Ladies and gentlemen, we have a very exciting penultimate session here for day 2 at the inaugural Abu Dhabi Global Healthcare Week on M42's main stage. We have a very esteemed speaker joining us. He's going to be addressing digital innovations in neurological care, enhancing diagnosis, treatment, and patient management. He is the Institute Chair, Neurological Institute for the Cleveland Clinic, Abu Dhabi, Dr. Florian Rosa. Please do join me on stage.
Thank you. I want to thank you very much for this nice introduction. And I believe I've given a lot of credits to provide an inspirational talk, right? There were a lot of panel sessions, very interesting to listen, but something inspirational gives a lot of pressure on me.
You do not need to feel the pressure because we are with you on this journey.
So when I was thinking about how can I inspire the audience for these 20 minutes into neuroscience, I was coming up with visualization. Because if you can listen to the heart, you can listen to your guts, but you can't really listen to your brain from outside. So you need to have a look inside. The brain is a closed box, so we need to visualize the brain and the brain function. So I want to move forward with the first slide.
Fantastic. Well, I'm going to give you the stage to move forward and allow you to delve into our brains. Thank you
so much. Ladies and gentlemen, so as I said, we need to have a better view inside the brain. And AI and innovation is going to help us much more to look beyond what is visible with the naked eye. This application I want to bring closer to you changed the way we treat strokes. It's an AI-empowered software which let us look far deeper into the brain than we used to see. So if you see this patient with a stroke, there's this very small dark area, that is the stroke. And about 20 years ago, when we started medicine and when we were taught about how stroke is, we saw that is the area which has suffered from that stroke. There's nothing we can reverse. But when we look at the modern software, we can look even beyond that, right? So we give the patient some dye and look at the vessels, and we see here that part of the vascular system is not supplied anymore. That is why the brain suffered a stroke. And 20 years ago, we would not be able to treat this patient because we would have told them that happened, there's nothing we can reverse. But nowadays, with modern medicine, we can open up the vessel again, but we need to be very careful when and how to do that. So this software is basically helping us with a lot of algorithms in the background to assess the area at risk. That means that is a brain area where the tissue is still viable and alive, but if you don't treat within the next hours and minutes, it might become a core part of the stroke, like the dark area you see. And this is what the software is showing us after a few seconds, that this is the core area of the stroke, and the green one is the area at risk. And obviously, what we try to avoid is the secondary harm. We cannot avoid what happened already, but we can avoid that this is getting worse. So this software is telling us within a few seconds, and we can even have this on the mobile phone. So the stroke interventionist coming into the hospital, knowing already what to do, what treatment option is better, whether we go in with a catheter and to remove the clot physically, or whether we can try to dissolve the clot. But this area at risk, this is what the stroke neurologist and the neurosurgeons try to help the patient with. Because survival and outcome and the future of the life of the patient is obviously much better if only a small area is affected than the larger one. So that shows us that modern technology, AI-driven software is helping us on a daily basis, not necessarily to avoid stroke, but to avoid the secondary damage most patients suffer on more than basically the incidental event. So this is a very first look at what is possible. So when you look at this slide, I want to go even more further into the function of the brain. Concentrate on the left side of the image. Everybody can see that this is an image of the brain, and something is not normal. There's a white, big shadow inside the brain, and this is something which doesn't belong there. This patient has obviously symptoms from the pressure of this shadow, this lesion, this tumor, pushing on the healthy structures. Well, this is on the left side of the brain. It's on the right side of the picture, but on the left side of the brain. So if this patient is a right-handed person, The left side of the brain is responsible for memory, for language, for speech, for generation of all these qualities. And you can imagine if we need to do surgery on these patients, they are at incredible risk to lose some of these functions permanently or temporary. So we want to look inside the brain. We know the anatomy, we know the morphology and the structures, but we want to have a look at the function. So this is a functional MRI where we ask the patient, we give them patient's tasks during the MRI scanner so we can make function visible. And the concept is pretty simple. This is nothing new. This is happening for 20 years. But the Cleveland Clinic Abu Dhabi and its surrounding facilities like the New York University, we did something different. And this is what I wanted to talk about with you today. So you can make the motor function of moving arms and legs visible. You ask the patient in the scanner to tiptoe or to do finger tapping. And this area of the brain, which is responsible for that movement, consumes more oxygen. And this is something which lights up because more blood is flowing to that area. This is the area which we can make visible with color coding in the MRI. The same we can do for language. And there are several language areas. So we give them patients tasks to complete a sentence, to rhyme, to spell letters. And so we can activate these language centers in the brain and can make it visible. And again, this is nothing very special. This is something we do for 20 years already. Now, unfortunately, science and medicine is dominated in the Western world. So all these protocols have been validated in English language, right? Not even in German, not even in any other language, it's English. And whenever you have a patient who's not native English speaker, you basically translate these questions and ask them these questions in Spanish, in German, or in Arabic. But unless you're really a bilingual speaker, where your mother or your father speak in different languages to you, the language centers of your primary and secondary language you speak are not necessarily in the same location. So now when you test an Arabic-speaking patient with an English-translated questionnaire during the MRI scanner, you might activate areas which are not the primary language area. And that is what we try to solve, and that is actually what you see here. So this is an Arabic-speaking patient who speaks fluent English, but he learned English by the age of 6 in school. He's fluent. You don't even know whether he was raised bilingual or whether he learned English as a second language. So he was in the scanner, and then we did the task in English and the task in Arabic. And then you see the difference. So the Arabic area is much larger. This is orange, and the English is blue. So now imagine you would concentrate as a surgeon only on to preserve the blue area, and you would compromise the orange area. You take away a lot of his culture, because if he's not able to understand and express himself in Arabic, he might be not as good as in English anymore. So that is very important. And the second problem is that, and there might be better experts in the audience than me, if you translate an English questionnaire just one-to-one into Arabic, sometimes you change the meaning. So what we did with the New York University, we validated an Arabic MRI testing for language with true Arabic native speakers and validated that so that we use specific testing and specific visualization, specific rhyming and specific sentence completions and letter spelling. So we have a much more validated functional MRI for language. So that is an important step forward, that we visualize these areas before surgery and translate these images into the OR so we have a much better outcome for those patients. Now the right side is something very interesting. So that paper has been published in October last year in Nature Neuroscience, which is a very prominent journal in the neuroscience world. Now they bringing the functional MRI much more forward. When we talk about improvement or increase of blood flow, and then you light up some colors to make language visible, what they do, they give the patient a very small story. And then they ask the patient to continue thinking about the story, how the story would end, like a small fairy tale. And then they ask, so like, what in your mind, think about it, what in your mind, how do you want the story to end? They should visualize that with their thoughts in their mind without talking. because you don't want to have movement artifacts with your lips, because then some other areas in the brain lightening up. So just with your mind, think about how would the story end. And with AI software and very sophisticated decoding of the MRI sequences, they were able to read the mind and have an 80 to 90% predictability of what the patient was thinking or having in his mind, how the story ends. And even the figures he was thinking about have been demonstrated by the software in terms of a printout that, yes, he was thinking on a young lady, or he was thinking on an animal, or whatever. So the predictability was about 80 to 90%, which is great. And it offers a huge pathway for us in the future to get more insights into the brain. But it's also a little bit scary. Can you imagine somebody is able to read your mind and extract these thoughts outside the brain? So the good news is in this research study that it only worked if the patient was compliant and was agreeing to that plan. So you can't extract this mind or these thoughts against his will. So the human will is still stronger, yet. So it's very interesting. It was published in September, and you see already a lot of publications and letters to the editors following that publication. So they're raising concerns in how we're going to protect the human mind, your own mindset, your will, your decision making. If this is possible, that in giving you a story, you can read the mind. Now, if we're going to get closer to these language systems I told you, and I just explained that we want to transfer this data into the OR, into the surgical theater, to have a safer surgery for these patients. So we take the imaging data and the functional data, bringing this together, and then we can map out the pathways. Because what is even more important is not only the language centers, it's the connection in between. As you can imagine, the most important are the pathways, the highways in the brain connecting these centers with each other. And as you can see here, we can rotate this in all planes, and we have to have an idea in what function surrounds that lesion, that tumor, and how I'm going to address it. And unfortunately for the neurosurgeon or for the brain surgeon, it's getting more and more complex in the future, because in the past we were thinking about 3 or 4 or 5 areas which are important, and the other one you can take out. But now the more we learn, the more we have to take care of that we preserve function as much as possible. Until 20 years ago, there were 2 language areas named by 2 neurologists from the 18th century, but now what we're going to do now is basically we look at 6 language areas and how they are connected, and if you disrupt any of them, you're going to have a problem later on. So it is very important to have this functional data which we gain from sophisticated AI-triggered softwares, to move them to transfer this into the surgical theater, and then with every instrument we use, we are at any time aware of the location where we are. And sometimes what we do, I'm not going to show this to you, it might be a little bit too scary, is we do surgeries awake, so the patient can communicate with us, and we do perform some of these tasks alive with the patient, stimulating the brain so we know exactly the function and can make a very conscious decision whether we're going to leave this area or we have to remove it, because there always needs to be a balance between what the patient needs oncologically and what he needs from a preservation of his function. So this is very exciting. The last slide I want to show you is something the Cleveland Clinic Abu Dhabi did last week, and it was the first of a kind procedure in the Middle East and especially for the UAE. That is basically touches the topic of epilepsy. We know that 1% of the population suffers from epilepsy. And in many cases, we find a reason. We look at the images and we see that there's an underlying reason for this epilepsy we can address. And most of the patients, they are very good with one medication, so they can live a normal life. But there's this subset of patients who suffer despite giving him one medication, a second medication. You add on a third medication and they still have seizures every single day. You look at the MRI and the MRI doesn't show anything. He has a healthy brain and still he has seizures. And then you look at the EEG. When we look at the electricity, a surface EEG, which most of you might know, but even you look at the EEG, and the EEG does not show us anywhere close a localization where these seizures is coming from. So these are desperate patients, and we need to really save their lives, because taking 3 or 4 of those very toxic medications is not healthy. And having seizures every day, of course, is not healthy for their cognition, for their performance, and for their quality of life. Now, what we can do now is we can place EEG electrodes into the brain, and this can be up to 20 or 30 electrodes temporarily, to have a better 3D picture, like a grid inside the brain, because each electrode has up to 20 channels. So if you implant 20 of these electrodes with 20 channels, you have about 400 recordings. And that requires a lot of teamwork. So the epileptologist, the neurologist, is giving us exactly the area where he wants to have some electricity measured. And our job as brain surgeons is to create a pathway, a safe pathway for these electrodes from the surface into their target. And at the same time, they should not meet each other. Some of the trajectories are not possible based on anatomy. You can't go through the eye, you can't go through the ear. So there's a lot of planning involved. And again, then you transfer this data of the planning into the software of your computer. And the computers are helping us. They're helping us with these trajectories. They're giving us a safety zone around these electrodes. We look at the vessels. We look at the anatomy of the brain. And the software is really telling us, stop, this is too dangerous. You're close to a vessel. And it's just a recommendation from the software. Ultimately, we have to make this decision ourselves. And then, once these electrodes are activated, you can read a 200-channel EEG 24/7. You have this patient in a monitoring unit in the hospital, and you can read 200 EEG channels. And it doesn't really look scary, right? He has these 20 cables outside the brain. It's very much secured. He can eat and drink in his bed, but he needs to stay in bed for 10 days. We stop the medication. If you want to go back with the slides, that would be great. And then just to have it run again. Thank you very much. No? Next slide. Yeah, this one, exactly. So just for you to visualize again. And then over these 10 days, you stimulate the electrodes. If you don't see seizures, you stop the medications. If you still don't see seizures, you can stimulate some of the electrodes to provoke a seizure. And then you know exactly by hundreds of milliseconds where is the real zone where the seizures start and where is it propagating from. So this is a very important step forward, and I'm very proud of my team who managed to do this. So the patient, we identified 2 areas where the seizure is coming from, and this is something you can then tackle surgically, right? That the patient now has a diagnosis, we know exactly where these seizures coming from, and then this area can be treated surgically in the next step in a couple of weeks. So that was a very exciting moment for us, and again, it's only the beginning. I want to explain to you in the last 2 minutes that if you use these electrodes in the future, there's a lot of research going on that these electrodes, who are 1.5 millimeter thick, and they have these 20 contacts, like I told you, but the next generation will be ultra thin, number one, and they're going to have 1,024 contacts per square millimeter. So if you have these electrodes with these numbers of contacts, you have a 3D dimensional image, functional image of the brain. And trust me, you can read mind and more than that, right? You can predict what the patient is doing 300 milliseconds after, before you read, 300 milliseconds after you read his EEG, you know exactly, you can predict what he's doing. Whether it's a motor movement or a voice or a thought or any other emotion he's displaying. So that's the next generation of these leads. And for now, it's just diagnostic. But as you know, sometimes we use leads to treat Parkinson's disease, to treat psychiatric disease. We start treating depression with these or obsessive compulsive disorders. For epilepsy, it's purely diagnostic. It helps us to localize the seizures. And that brings me already to the end of this inspirational overview. Open the door a little bit into neuroscience. and so you have an understanding of how innovation and AI and technological advances really help us to diagnose and ultimately treat the patients in a much better way. Thank you very much. Microscope is not.
I'll project.
Your project. I predict.
You began by saying that you were going to deliver a very inspirational talk, and how to do it. You certainly hit the nail on the head there. Opened our brain boxes by opening your brain box. Thank you so much for that.
Welcome.
We can't possibly allow you to leave the stage without an official photograph of you here at the Abu Dhabi Global Healthcare Week. Fantastic.
Thank you.
And I know that we didn't have time on the clock to allow for you to interact with the audience, but if I can vouch for this being a very approachable gentleman, I'm going to introduce the next panel discussion in just a moment. But please do approach him. Dr. Florin is with us to network and to answer your questions directly. So please do grab hold of him. I think I can vouch for you.
Absolutely.
Fantastic.
That works out. Thank you very much.
Another round of applause, and we're back in 2 minutes. Thank you.